Hospital, where Dr. Voudris and Onassis team are doing an alternative approach case of TAVI. So, Vasily.
We are live.
Yes,
Okay.
Ilya.
Do you hear me?
Yes. Nice and
Good
clear.
afternoon. We're in cath lab of the Onassis Hospital, the same team. I don't know if Dr. Finkelstein is in the room. Our vascular surgeon, Dr. Nikos Doulas, and Dr. Mustafalis. The interventional cardiologist, Dr. Sbarouni, the anesthesiologist, Dr. Fikos and Dimitris, our nurses, Irini and Marina, the people of the company, and of course, the heart of the TAVI program in our institution, Dr. Martina Papageorgiou. I think that we're ready to show you a very, very difficult case, and Dr. Kosmas will present this patient.
So thank you, Dr. Voudris. We're going to show you a very interesting case. It's about a very young, 87-year-old kind lady with gradually worsening airport dyspnea, arterial hypertension, dyslipidemia, pulmonary hypertension, moderate carotid artery disease, and elevated surgical risk scores. From the screening, you can see that the coronary angiogram revealed no significant coronary artery disease, and the echo preserved ejection fraction with severe aortic valve stenosis with gradients 65 and 46. Here you can see some images, the dysplastic aortic valve, the elevated gradients, and preserved ejection fraction with mild aortic regurgitation. From the CT angiography, we have to highlight the very not promising femoral artery dimensions and the severe calcification, and as well as the heavily calcified aortic annulus and the calcium extending from the annulus to LVOT and then LVOT hypertrophy. Some more images, promising heights, and here you can see the severe calcification of the aortic annulus and the calcium extending from annulus to LVOT. Here you can see the exact dimensions of the femoral arteries as well as the heavy calcification. And to move on, here you can see some videos from the 3-Mentio program. We can see also the heavy calcification. To move on, we analyzed the subclavian artery. The right one has a severe calcification in the near the aortic arc, while the left has a severe tortuosity with small dimensions. Here you can see also some videos from the dimension. As for the valve selection, 29 is our choice, Evolut FX. So the heart team of our hospital decided that catheter aortic valve implantation should be the optimal strategy. And here you can see the vascular surgeons prepared the right subclavian artery. You can see here the prosthetic vascular graft down to the right subclavian artery. Some sutures here. And here all the team now is checking that everything is all right, so we can proceed to the procedure. So, Dr. Voudris.
Okay, thank Dr. Kosmas. Is there any comment from the chairman or the panelist or from the other people in the room?
Yeah, so Vasily, in the panel, we have Dr. Patsalis, Dr. Georgiou, and Dr. Michalis. And we have also Professor Tsoufis, Dr. Marelis, Dr. Halapas, and Dr. Stavridis, Avgerinos, Antoniadis. So there are a lot of cardiologists and cardiac surgeons.
Okay, so I think that we can move to the case, arterography from the right femoral artery, calcification. Then we try to advance the guide wire through the right subclavian artery. You can see how difficult it is. Next, please. Because of the tortuosity and the calcification. So we put a small sheath and we have an angio. Have a look how the right subclavian artery is going. Next, please. No. Just before Martina. So we try to enter through Noblat's left catheter to the right, to the left ventricle. Next, please. And this is the 18 French central sheath. We decided to put 18 French sheath so we can insert everything, balloon and the valve from the sheath to the aortic position. And then just, this is the pre-dilatation with a 24 millimeters balloon. And if there is no comment, we are ready to advance the valve.
Okay, it's an interesting case. So, Aki, would you have a different approach? Would you consider any other access?
Okay, Dr. Georgiou, Dr. Michalis.
I think you have done a very good job there, and I think we are very interested to see how you will proceed with this right subclavian, which is not the easiest one because the angle usually is a bit difficult, especially for balloon expandable valves, self-expandable valves, and all the companies and everyone sort of suggests that it should be a very shallow angle in order to have a good result. But I'm sure you will do it in a very nice way.
Exactly. The tension of the system is the big question here, how much tension we will have due to the kinking. But it's very elegant until now, and we're looking forward for the rest of the procedure.
Okay, so if there is no other comment, let's go. We are ready to advance the valve. Let's go. Σιγά, σιγά, σιγά. Σιγά, σιγά, please. Okay, please. Please. Slowly, 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 slowly. Okay. As you see, it's not so easy. We have the same problem with balloon. For this reason, we decide if it's possible to put at the beginning of the procedure an 18 French sheath to be much easier to make everything. Okay. Yes, ortho, please. Okay. Leave of your down. That's okay. That's okay, Stefana. Okay, that's fine. That's fine. So, to see the pressure, Martina. Yes, please. Please, because they cannot see. It's possible.
So the valve comes from the inner curve, as mostly happens when we go from the right subclavian.
That's a problem we have
Yes.
many times, as you know, John, with the right subclavian artery.
Any comments? We also have remotely Dr.
Amphitheatre.
Kolokathis, who
Moment.
is available for
120.
any comment.
120. Okay. Angio. Angio, Martino. Okay. It's, that's fine.
And you could appreciate the tortuosity
Yes,
and the
140.
moderate stenosis of the subclavian. So
TSF here.
every
TSF
movement is
here.
really difficult here.
160. Don't worry. 170. Okay, 120. 100. We'll see. We'll see. Okay. Angio. Yes. So close it. I think that we should move. 120. Okay. Proximal. Κι άλλο, παρακαλώ. Κι άλλο. Okay. Stay there. Μην πάει άλλο. Okay. Άντζιο. Πίεση Παναγιώτη. Okay. Πίεση Παναγιώτη. Πιο πίσω. Ναι, εντάξει.
So it's always the issue of coaxiality and
Όχι,
here and the right
140.
subclavian.
Γράψε. Γράψε, Ματίνα. Okay, that's fine. 140, 160, 170, 120. Okay, that's fine. Δεν βλέπω την πίεση. Το βηματοδότη 120-100 παρακαλώ. 180. Okay. Let's go. Ναι, Άντζιο. Okay, it's fine. Okay, close.
So maybe
120.
we need to work on the trajectory.
Sorry.
Do you have a tip? How do you deal with that? So when you are coming from the inner curve,
Exactly.
sometimes if you
Κι
play with the wire,
λίγο.
just push it a little
Εκεί.
bit and then
Yes.
to
Okay.
achieve some more coaxiality.
120.
You have named it, but to the point, your comment is this is the problem is that you come from the inner curvature, you don't have a natural positioning due to the anatomy. The only solution is to try to start really, really high with push of the wire
Okay.
continuously and do a really slow
Γράψε Άντζιο.
development. but it's a very difficult constellation.
Yeah.
Okay, fine. 140. 160. Μείνει από εσείς ευτυχία. Πολύ ωραία. Τέλεια. Okay, that's fine. 100. 80. Κυροσκόπηση ευτυχία. Okay, γράφουμε. That's fine. No, because as you see, that's fine. Λοιπόν, may we see this on the other side? Κυροσκόπησης. Okay, it's good. Εντάξει, γράφουμε. Ναι. Okay, fine. Λοιπόν. That's fine. Όχι, εδώ πως είμαστε. 140. Κοινοσκόπηση. Εκατόν 160. Λίγο καλύψου, πήγε. Οκ, 170. Οκ. Θα δεις πώς θα καθίσει τώρα εδώ όπως είναι. Οκ. That's fine. Οκ, 100. Did you see the movement of the valve?
So it moved up from the left a little bit.
Exactly.
And there was a reorientation of the valve.
Κοινοσκόπηση, PA. Κοινοσκόπηση. Μην κάνεις τίποτα ευτυχία, εσύ ως εμένας. Μπορούμε να το περιστρέψουμε και όταν
So at
αντίθετο
this point, the sheath of the valve is inside the 18 French sheath.
Τι? Ναι, όπως το κλείνουμε. Κοινοσκόπηση.
So in order to close the valve, it needs to be willed. Okay.
Excuse me?
No, you're doing exactly this movement. You're showing very eloquently the movement that needs to be done.
Αντίστροφα, έτσι.
Any comments from the audience? Dr. Georgopoulos, you have extensive experience in Evangelismos Hospital with subclavian.
To be honest, we prefer the transcarotid access than the transclavian. And from the right side, it's more difficult. The orientation is more difficult. I have never done it from the right side.
Άστο. Πρέπει να βγει όλο πίσω, μπλοκ. Τράβηξε λίγο θηκάρι πίσω. Λίγο θηκάρι πίσω, παρακαλώ πολύ. Λίγο θηκάρι. Οκ, πρόσεξε. Οκ, fine. It's fantastic. Don't worry. Out. Ανακτηνοσκόπηση. Η Ματίνα, να βρω το θηκάρι, να βγάλω το θηκάρι, please. Πάμε πάνω. Πρέπει να βγει ένα μπλοκ όμως, έτσι. Πάμε. Don't worry, Νίκο. Ατίνα το από το σερβατόσμο. Κοινοσκόπηση. Το σύρμα. Κοινοσκόπηση.
So
Okay.
So you are working with a Confida wire or it's a Safari wire?
With Confida. Actinoscopy. Okay, so now we're ready for the angio. That's okay. That's fine. Let's go.
Do you think, Giannis, that with a stiffer wire it will be more easier to approach?
Well, this is a nice comment, Donny. Yes, when we have tortuosity, sometimes it's better, but sometimes when you use a less stiffer wire, you can play with the wire a little bit more. Maybe you can reorientate the valve, and maybe you can go a little bit easier from the inner to the outer curve, but it depends. And definitely, if there's a 34 valve, we need to have a Landerquist wire.
Okay. Satisfied?
But as you see, after the deployment of the valve, the valve moved in the self-orient. We have self-orientation of the valve, so now the height looks quite good. Do you agree? I guess.
Taking the difficulty into consideration is excellent. It's very difficult access. Great job.
Yeah.
Okay.
Good.
Is there any comment?
Would anyone consider post-dilating this valve or interrogate further?
I would be interested to have the hemodynamics to take this decision.
Yes. Maybe we should be doing some hemodynamics. Let's place a pigtail inside the left ventricle and measure the gradient.
Generally, I would be very less is more.
Don't forget the complexity of this case.
Is the best way.
Yes, definitely. It's very complex, and you can appreciate here. Now that we have the wire out, you see the movement of the sheath. So it's a lot of tortuosity, moderate stenosis at the subclavian artery. So yes, it's not easy to do all these things. I agree. Good.
Vasilis, I think it's a very good result. Congratulations.
Thanks so much. The whole team, because for this case we need a team participation.
Yes,
Otherwise, it's impossible to have results.
Definitely, and don't forget that we have the vascular surgeon, who are really part of the heart team in our hospital. So thank you for that, and we have to proceed. So thank you, Vasily, and thank you to all the team that worked for this.
All the people with us. Thanks so much.
Thank you.
Το διαστολέα. Μισθό στο διαστολέα.
So, and now we have